A very warm welcome to the group board meeting of Bristol NHS Group, comprising our two trusts, and a particularly warm welcome to colleagues who have joined us as observers today. Good to see you all, and very welcome you are too. We do have one apology from Paula Clark. Other than that, we are all here. Today is Armistice Day, so at 11 o'clock I propose that we do observe 2 minutes silence. Maria, it might mean cutting you off in your prime mid your report, so forgive me if I
merciful
do
release
that.
for everyone.
But so at 11 o'clock we will be doing that. Are there any declarations of interest specific to today's agenda? No? Okay. In which case, a very warm welcome to Sarah. Sarah Wolf has come to share her experience and story with her, and I think Emily and Steve are going to do a brief introduction. So great to have you with us, Sarah.
Great. Thank you. So I had the pleasure of meeting Sarah last week. We had an hour and a coffee together, and Sarah's story and experience is really quite compelling. Emily is head of patient experience at NBT, and we're going to have kind of an interview style approach for the next 10-20 minutes or so. We are handing out something for you to read, but Sarah will tell you when to open. Sarah, over to you.
Thanks, Stephen. So welcome, Sarah. Can you tell us what you would like to talk to us about today?
Yes, well, it feels like a gift actually to have this opportunity to talk to you all. So thank you very much for inviting me. I'm actually going to talk to you about a short and very honest note that I wrote to the surgical team when I came to South Green Hospital for treatment for breast cancer. And this one note took me by surprise, and I think probably everybody there, and it changed everything for me. And what I discovered, I've written in 2 articles that I've had published in the British Medical Journal. What I discovered, both from my own experience, but also from the work that I did in hospice care, were 3 key things. One was that the mental and emotional impact of ill health and treatment can be as bad or worse than the physical symptoms. The second is that our healthcare often doesn't recognise this. It compartmentalises our health and focuses on the physical body part, but often in doing that overlooks the person. And what I discovered is that that can actually make the psychological effect of ill health much worse. What I discovered from my note was that how the staff interacted, so that humanity, their emotional intelligence, their listening to me and validating me as a person, that changed everything and actually formed a treatment for the psychological effect of my treatment in ill health. So I'm going to tell you a story about my note, and I'm going to invite that you as a trust to take just one simple step, which my hope is will lead towards a new, emotionally intelligent era of healthcare. Yeah.
Thank you, Sarah. Could you tell us a bit more about yourself and your work?
Yeah, thanks, Emily. So as you can see, I'm Sarah, I'm not a disease. And like all of you, I have a meaningful life. So do the staff, the visitors, all the patients. Everybody who comes to your hospitals has a meaningful life. And I live locally here. With my partner, we have 4 adult children, grown-up children, and 2 lively grandchildren. I love being in nature. I love walking my dog and wild swimming at Henley's Lake. And I love dancing. And I trained as a dance movement psychotherapist here in Bristol and worked at the hospice in Weston-super-Mare, Western Hospice Care, for about 10 years. And while I was there, I ran a group which I called an expressive movement therapy group. And I did the first research in the UK about that group. And my findings were published in the International Journal of Palliative Nursing. Now, one thing that I suppose, a privilege of working with both mind and body as a psychotherapist is I was able to hear about the link between how people's physical health affects their mental health and vice versa. And I'll give you an example. There was one gentleman who I'm calling Charles, that's a pseudonym, who came to the group in a wheelchair. Now, it turned out that Charles had very bad arthritis, but he didn't talk about his illness. Actually, he was very depressed, and the burden for Charles was actually being seen as a person in a wheelchair, because actually it turned out he was a really sporty man. He'd always been, and he was a very masculine male. And actually the healing for him and everybody in the group was being seen as a person who they were beyond their illness. Being defined by their illness actually was causing him the psychological pain. So it was very clear that emotional intelligence, that listening and validating the person, actually formed the treatment for the psychological impact of their illness. Yeah, thank you.
So it sounds like their psychological pain seemed worse than their physical pain.
Yeah, often.
How interesting that emotional intelligence acted as a form of treatment for that. So Sarah, can you tell us how this might have played out for you as a patient?
Yeah, thank you. So it's really, I started off actually very well, both emotionally, and actually I felt very well physically. But one day I was in the shower, and as you do, you know, I just wash it away, and I found a lump under my armpit, went to the GP, and was sent to the breast care centre at Southmead and was diagnosed with breast cancer. My life turned upside down. I had to stop work very abruptly, and I was thrown into months and months of very, very brutal treatment. So I had months of poisoning with chemotherapy. I was cut with surgery and biopsies, and I was burnt with radiotherapy. I was also given hormone treatment, which made me very ill. And I developed very, very bad fatigue. Now, that actually, the effect of that meant that my life actually got cut out. I could barely take a shower without getting exhausted, couldn't be there for my children. And what happened was that I too became depressed, and I suddenly realized what was going on, that I was grieving over the loss of the person that I had been, that social, spirited person that I'd always been, and the meaningful life that I had led. So I actually, the effect on me psychological was very bad. And it reminded me of one of the clients who'd come to my group, who had taken a piece of white net, draped it over themselves, and said, "I feel like a ghost of my former self." And that is how I felt. When I came to the hospital, there was no recognition of that at all. There was no understanding at all of the psychological impact of what was going on for me. And in fact, it became very compartmentalized. So there was a real focus on getting rid of my physical symptoms, which obviously needed to be done. But in so doing that, I became completely overlooked as a person. So they seemed lovely people that I met, but they hadn't been trained to recognize the psychological, the emotional impact of what they were doing, and also what was going on for me at home. And I felt so overlooked that I actually felt invisible, more and more invisible, outside and inside the hospital. In fact, I think my partner Cantor had over 100 appointments. In almost none of them did I see the same person twice. There was no sense of understanding that the relationship between me and the staff was actually what was needed as a form of treatment for the mental and emotional impact of what was going on. In fact, I ended up feeling like a car being passed around a factory, having my body parts being tinkered with. And at one point, the radiotherapist, and this was not out of the norm, put their notes on my legs like my body was not part of me as a person at all. So I developed something which I now know is called medical trauma. It's like a form of PTSD, and it can affect people whether they have chronic or acute illness. Now, about 2 years ago, unfortunately, in a routine scan, some more abnormalities were picked up in my other breast, and I was told that my breast had to be cut off. Now, I don't know if you can imagine that I was already in a very traumatized state. To be told that was very, very hard. And I tried talking to my surgeon, and I tried my consultant, but she hadn't been trained to have any literacy around that or to understand, and felt a bit out of her depth, I think. And actually just talked more and more about the treatment, which of course made things actually worse for me. And it became so bad that on the day of my having to come in, so I don't know if you can imagine, I actually voluntarily had to come in to have my breast cut off. I actually did something that I've been told has never been done before. And I just wrote down my feelings on a short note. And I brought it into the hospital and I just gave copies to everybody. And I know if you can imagine. So there I am, really nervous, sitting there in the pre-op room with one of those awful flimsy gowns that you do that don't do up properly. And the surgeon came in and I just handed her my note. And each of you should have in front of you, I hope, the notes. If you'd like to open it and read it now and imagine what it was like for her reading this. I'm going to read it out to you at the same time. It says, "Please be aware that I struggle with medical trauma. I don't know how I will cope emotionally with having my breast removed. I also wanted to ask if you could take a moment to acknowledge that my left breast has nourished my 2 children with milk, has given me pleasure and has been a tender and much loved part of who I am as a woman, and I will really miss her." And it even makes me feel quite emotional now, thinking and reading about it. What happened took me completely by surprise. It was like the divide between us disappeared, and she looked up, instead of seeing me as a piece of breast tissue, saw me for the first time as a fellow human being. It was like we met in a really human way. And she even took the note and she had it read out in the operating theatre before surgery. And the person who read it out came and met me afterwards. I can't tell you how grateful I am, how I would like to thank the team. I'd like to thank them for their humanity, which to me was actually more important than their clinical skills in helping me heal. Not just my body, but my mind and my soul too. So yeah, very grateful. Thank you.
Thank you so much for sharing that. It's really powerful. Your note seems to have really changed the way that staff treated you.
Yeah, it really did.
So what can we as a trust take from your experience?
Yeah, thank you. Well, I have to say I'm extremely grateful to talk to you today. I know that you as a trust have a reputation for innovation and leadership and outstanding patient experience. I'm also delighted that you've taken the lead in putting together a mental health strategy for the trust. What I want you to do now is actually take a whole new further step towards what I believe needs to be a new emotionally intelligent era of healthcare. I read that the World Health Organization defines health as the complete physical, mental and social well-being, not just the absence of disease. But in practice, our care has become very compartmentalized, where we're treating the body parts but overlooking the person. Now, I know the Hippocratic Oath says, do no harm or the equivalent, yet this is actually adding to the burden of people's psychological pain when they are ill. And I am quite sure that if people left the hospital bleeding more than they did when they arrived, practices would change very, very fast. Now, I'm well aware that money is very tight in the NHS. But I read that in 2022, something like 5 billion was spent on research to improve our healthcare. What I'm talking about doesn't require any new expensive resources, no new drugs, no new equipment. You already have the resources that you need, which is caring and dedicated staff. Now, I know that staff are under time pressure, but it isn't about adding more tasks. It's about doing the same work that they're doing, but in a more human way. It's about not what they are doing, but how we interact with each other. Now, it could be easily combined, and it needs to be, with clinical practices. So, for example, if somebody is taking bloods, they could at the same time be saying, "How are you feeling?" or "How is this affecting you at home?" Or taking it while you're talking about treatment plans. So I know that there's a new NHS 10-year plan coming, and I believe there's greater emphasis on patient experience. And I know there's things like About Me program and personalised care and so on. But what I'm talking about is a complete culture change, actually. It's about moving from a medicalised approach to combining our care for people's emotional well-being at the same time as caring for the physical effects of their health. So I slightly feel like I'm in Dragon's Den right now. But actually, Dragons, I'm not going to ask any of you for any money. I'm actually going to ask you to take one small step and run the very first pilot research study in just one of your departments or one service in one of your hospitals, where you actually set some standards about what we need to do and then embed emotional intelligence, EI, in all of your patient interactions and interventions. So a lot of creative ways that could happen. Training staff to combine their emotional intelligence with their clinical skills and putting the person themselves at the forefront and center of everything. So whether it's, putting it first in people's notes, writing above people's beds who they are, not just their medical condition or whether they can mobilize to go to the toilet, and find out, be curious about what is actually important to them and what matters to them in their lives. Measure patient well-being and their outcomes before and the outcomes after. And my hope is to get the evidence that you can then roll out across the trust. And my hope is across the whole of the NHS. My notes showed me what I think mental health practitioners already know, that emotionally intelligent human relationships are the healing and the treatment for people's mental and emotional well-being. Now, with technology and AI coming in, those important human interactions are being eroded. We know now from COVID what happens when those important human interactions are taken away and how it affects people's mental health. Emotional intelligence, EI, is going to become as important as AI as a form of treatment in the future of our healthcare. And I just want to say that putting the person before their symptoms costs nothing. But as I discovered, it changes everything. So my note and the effect it had healed me in mind, body, and soul. I want to ask each of you, ask yourselves what you yourselves can now do to take the steps that are needed to move us into a new emotionally intelligent era of healthcare so that this happens for every person, every time. Thank you very much for listening, and thank you for inviting me. Before I hand over to you, I just want to say, I'm afraid I only bought enough for the execs, but I bought the gift as a book for those people. I'm afraid I didn't have enough for everybody, but if you'd like to help yourselves after the presentation.
That's very generous of you, Sarah, and generous giving of yourself in what you said here today as well. So thank you.
Thank you.
Hugely appreciated. Colleagues, are there points that people would like to follow up on, and maybe particularly around Sarah's specific challenge? Steve, I bet you've given this some thought.
I have.
And Gifty as well, with the mental health, the author of the mental health strategy for MVT. So,
well, Sarah and I have given this some thought when we met last week with Emily. And Sarah's challenge about could we do some research or some pilot, I think it's a great one. What we started talking about though was, so what is it? How do we describe? How do we take the essence of Sarah's experience and probably others to define what a program or a pilot would be? And I think what I've committed to do with Sarah is to work on that, to work through what that might look like, and then we can do something with it. So I had a very cherished hour with Sarah last week, which was very, very special.
So that sounds like the right approach, to co-produce it based on your lived experience, because then we'll hit the right buttons.
And hopefully others as well, as you say. Yeah, I think.
Other thoughts, Maria?
Thank you so much, Sarah. I think as the two trusts came together, we've committed to deliver something called trauma-informed care, but we're very much at the start of our journey. And it would be lovely to, if you have some time, to work alongside us about how we help and support staff to see the whole person and understand that we're products of background and experience. Exactly. And that comes in with us to our hospital appointments and to our procedures. And I think it's very meaningful for staff and for patients to understand that that's what we're trying to do. It's often been in the preserve of a mental health trust,
Exactly.
but that ability to put mind and body back together again is something that we are aspiring to, although very much at the start of our journey. Gifty with the mental health strategy, some of the HR work, Jenny, that you're overseeing, we are trying to move in this direction. So it'd be lovely to work alongside you as we try to finesse and roll it out. Staff are really interested in it, and it feels like it'd be very enriching on for staff and patients.
That sounds excellent. And, I think also, it obviously will filter back to the training. Obviously, it goes all the way through. I'm actually in touch with an international collaboration, which is trying to be set up at the moment, about people who are specialising in medical trauma. And they've invited me to be part of that conversation. So it'd be really good to actually I'd love to be involved in that. Thank you very much. Excellent. Yeah.
Jenny.
Sarah, thank you. This is my first board meeting.
I was
Without a doubt, the most powerful patient story I've ever heard.
Oh, okay.
Because I really liked the call to action that came with it.
Yeah.
So definitely, Steve, I'll work with you. I think the description of it being a culture change is massive.
It is massive.
So, I'm thinking my team at the minute putting a huge amount of thought and effort into the culture change that comes with a potential merger. And actually, your challenge back to us here today is, and what's the culture change that needs to be wrapped around just the way that we think about healthcare in a hospital setting. So
Yes.
Thank you for the challenge, and I'll definitely co-produce it and work with you and Steve on it.
Lovely. That's really lovely to hear. Thank you.
Mark.
Thank you, Sarah. That was a really powerful first story, so thank you for sharing that with us. I just wonder, and you hinted at it in terms of the training, obviously this group employs a lot of students
Yes.
from across different backgrounds, both at registration level and otherwise. I'd like to think this work could go even deeper into the workforce of tomorrow in terms of how because as far as I'm aware, I'm happy to accept challenge here, the element of what you described, I don't think features enough, and I'm saying that as someone that works in an education institute. I don't think it features enough
No, I agree.
in the undergraduate curriculum. If it does, it comes in the final year of study,
Yeah.
and that's both, I think, for both medicine and for nursing and AHPs. So what would it look like if something was done and developed to actually support that as well? I think that'd be really powerful because it starts with the future workforce.
It really does. I mean, really pleased you brought that up. Actually, my son is actually a medical student in Cardiff, and he's a very compassionate and empathetic young man.
Sure.
But then I went to some ward thing that we were going to, and yet they're still just talking about body parts and the tasks. And I actually challenged one of his, one of his friends who were in the pub actually. And I said, I actually found it very disturbing to hear the way you're talking about it. And he suddenly changed his tune and he said, yeah, actually my dad, he's had heart problems. And he's just Steve. He just wants to be known as Steve. And he said, he hears people saying, oh, bed 34. He said, I will never, ever say that. And, they're willing and open. But from what I can gather, some of the emotional intelligence has been taken out. I mean, I could talk a lot about that, but I feel very strongly about it needing to come in from very early. And a lot of it also around the language that we use is needs to be changed.
Language approach. But thank you, Sarah.
Thank you very much. I'm delighted. Yeah, thank you.
Sarah and then Sue.
Thank you, Sarah. Very powerful and moving. So sort of building on from Mark's point, in Bristol, we've tried really hard to train our medical students, not, I think, with the depth and insight that you've talked about, but in that direction, trying to, all students study holistic medicine and spend quite a lot of time learning about communication and viewing patients as people. But I'm not saying that's perfect, but
No.
I think many young people come, as you describe, with compassion, but actually things happen to them when they come and start work. And I think we need to look, building on what Jenny said, as an organisation and more widely across the NHS, about how we then expect people to work, how they become disillusioned and tired, and how we then try to ensure they can keep the patient as the focus, the person as the focus of what they're doing.
Yeah.
So I think that's another area that we need to be very aware of.
Yeah, thank you.
Thank you, Sarah. Really humbling, actually. Actually, I find it quite sad listening to your description. As a registered nurse myself many moons ago, and I was thinking about training, and I'm thinking we do train, but my challenge actually isn't to you. It is back to the execs to say, when we admit a patient to a ward, there is meant to be a holistic assessment. So, are we really convinced that the holistic assessment really takes into account of the whole person, or are we just going through the motions? And you gave a really good description of a pre-op assessment. Now, I had surgery myself 7 weeks ago, and I went through 3 pre-op assessments, and I can tell you, not one pre-op assessment asked me anything other than checking my blood pressure, doing my bloods, all physical. There was not one question around how do you feel about your surgery, the emotional health and well-being. That is really basic. So my question is not for you about doing your research, because actually, sorry, Tim, what the hell are we doing if our basic pre-op assessments doesn't include listening to patients to say, how is this making you feel? What are you worried about? What are you anxious? That doesn't need a research project, that needs going back to basics and saying, are we really sure we're doing the right thing for patients? Because it kind of doesn't feel like, and I felt like that, and it was an experience, and so for you, it really resonates. So thank you, really, really important message.
And also, I think, because you talked about how you're feeling, and also beyond that, so often what I've heard about, things about, how you're feeling, whatever, or personalised care, is specifically around the physical treatment, so improving clinical care. But actually, what I discovered is that it's seeing the person, actually finding out who the person is. Because, Ingrid and I were talking about, just a broken finger can mean completely different things to a different person. It could be nothing to one person. But I was just saying, if you're a concert pianist, that would change your life.
Absolutely.
And, so everyone is so, so different. And as you say, it takes very little. But actually seeing the person as a person, we're very task focused and not human focused, and that needs to be turned on its head. Thank you.
Thank you. Tim, did I see you twitching there?
As a surgeon in the room, I started to if I was being, as eyes were looking at me. So thank you very much. And I think not all is lost. I think there are a number of sort of more forward-thinking surgeons in both of our trusts who are trying to address this. And it's not a standing start. So some, perhaps the MBT board members will be aware that previously we have reported back on the MBT shared decision-making program. This is groundbreaking. This is research, and it is being published, including in the Lancet recently. Shared decision making is all about patient-centric approach, particularly to surgical conditions. We've launched it in colorectal surgery, but we are hoping to push this now, having proven the concept into other surgical fields. And I think actually what made me put my hand up was the preoperative assessment, because it actually starts prior to the preoperative assessment, where the patient is contacted with a very wide-ranging list of questions and prompts, and most of the responses we encourage are free text, and it is about the person, about your thoughts and emotions. And actually, the intervention is such that we have stopped or halted 12% of cancer colorectal operations before the patient comes to the hospital for that surgery, to have further conversations with them. And they are partly related about misunderstanding and miscommunication and consent, but an equal number have been because the patient's emotional and psychological well-being had not been fully captured. So we are making inroads. Okay. It is a small step in the right direction, but our shared decision-making programme is now funded by £4.3 million worth of NIHR grant, and we have appointed a chair. Surgery specifically to take.
For letting me know that.
So some progress.
Yeah, thank you.
Okay, so some encouragements, I hope, Sarah, from what Tim's just said, the trauma-informed care work that Maria's talking about, Jenny's commitment to working on the culture change, because it is massive.
It is
let's
massive.
not kid ourselves. This is
It is.
Steve will work with you on a specific research project. And what has really struck me, Jenny, is you are a whole person. We are all whole people. We're not just a bundle of symptoms. And one of the other things that hasn't been mentioned around the table is the what matters to you approach, which both trusts have embraced. But actually, if you ask that question right at the beginning, rather than what matters, what's the matter with you, what matters to you,
So really good approach. Yeah.
you actually get a very different conversation.
Yes.
And that's something that we're working on as well. So thank you for your time. Thank you for giving us such a powerful story. I know it's had huge impact around the room. Thank you for the books. And thank you for your ongoing engagement with us. Thank you so much, Sarah.
Oh, it's a pleasure. Thank you very much for not only listening, but really listening. Thank you very much indeed.
Our pleasure and privilege. So it's really interesting because that built a bit on the story we had last time from the Macmillan Wellbeing Centre. When Sarah, we were also hearing from people who were undergoing cancer treatment, and through the Wellbeing Centre, they were having experiences, activities, peer support that absolutely address the whole person piece.
I mean, obviously, but
Yeah.
I mean, there are that, but I suppose it's the combining rather than having it separate that's important.
Absolutely, got you.
Yeah, thanks.
Okay, thank you. It always feels like a bit of a come down going to minutes after something like that, doesn't it? But here we are. So let's have a look at the minutes from our September meeting. Are there any amendments that anybody would like to flag?
Chair, just a correction in the title, the first page. I'm the group CNO, not CNO.
Ah, okay, thank you. Good spot. Any other amendments? No, so we will accept them as a fair record. There are a couple of matters arising on the action log. The first relating to the addition to the board assurance framework of a specific risk on no criteria to reside.
Thanks.
Xavier, do you want to say something about that?
So there's two actions, both are closed. It's just unusually board assurance framework, which has had the risk added to it. The report to which it's appended is actually in our private session this afternoon due to the nature of some of the matters that are going to be discussed under that item. However, it is the general practice for the board assurance framework to be received in public. So I've asked the governance team following the meeting to ensure that a copy of the board assurance framework is published along with the public papers, and we'll ensure that those reports are speak out in the future so that the BAF appears in public. But just for the board's assurance, that action is now closed. There is a risk relating to no criteria to reside on the BAF. The other action is also closed relating to board work plan and committee terms of reference.
Okay, thank you, Xavier. Any other matters arising that have not been caught in the log? Okay, in which case we will move on to questions from the public. And we do have a written question which has come in advance of the meeting. Xavier, do you want to tell us about it?
For sure. So I have a copy of the question here and a copy of the answer, which I'll read for the purpose of board's awareness and for the minutes. So question from a member of the public who lives close to the UHBW Central Hospital in the centre of town. So how does the Trust assess whether it lives by its values when considering the impact of decisions on their near neighbours in Kingstown? How is such an assessment regularly made, and how is it reported back to the council? Further background the member provided is, in short, we live very close to the hospital, so close that we can hear heart monitors in the summer. We, along with our neighbours, are often overlooked by the hospital when it makes operational decisions, and the impact that this can have on our well-being. Things have come to a head recently, and there needs to be a better and more coordinated approach. So the response is from Mr. Van Etchescliep. So we're very grateful this question's been raised. We recognise the importance of being a good neighbour and really value being part of a thriving and close-knit community in the heart of Bristol. and keen to strengthen our relationship with local residents and to ensure that the way we operate reflects our values and takes into account the impact of those who live nearby. So our Chief Communications and Engagement Officer, my colleague Elliot here, has offered to meet with this individual to discuss how we can engage more effectively with them and with their neighbours on a more regular basis, to explore how we can continue to improve our overall approach to local engagement. So I think an interesting and important question, probably one that needs a little bit more exploration, but that offer has been made.
Thank you. Good at some point to have some feedback about what that further engagement actually looks like.
That's a big capture and action to the next public board then, which will be in 2 months' time. We'll see if there's an update.
Thank you very much.
I think having ongoing conversations and dialogue with local residents is really important, rather than just responding to communication. So I know certainly we often do around planning applications. We will have lots of discussion, but it does feel like we could have more. I suppose steeping being our anchor institution, discussions with local residents about what's important to them as well, through having something regular set up. So can we think about what that forum could look like, perhaps as a shared, but often residents just want to know what's going on around their local patch. So we might want to think about that a little bit differently rather than group. Just have a look in the, be it Cosham, be it, I had Cosham the other day. Local people have got views about that as well that would be good to capture.
It's incredibly important. Absolutely something we'll be looking to do as part of our engagement approach. I'm very happy to bring it back down in a couple of months' time and report back on that.
Thank you.
Okay, great. So more to come on this. So thank you. Sarah?
Thank you. Elliot, I just wonder, there might be some useful learning from the University of Bristol. They do have regular outreach to the community, and just some of the models they've used, it might be useful just to understand what's worked well.
That'd be fantastic.
What hasn't? If happy just to send your contact separately outside the meeting.
That'd be wonderful. Thank you so much.
Good idea. Have any of our friends that have attended today got a specific question, Ben?
I've got one, if you'll permit me. So I'd just like to take this opportunity to seek some assurance on the final position of the winter plan, because I know it's mentioned in the upwards reports, and I'm sorry if it's jumping ahead, but it's something that has come up considerably with my constituents, and I'm hoping we can take this opportunity to assure them that the group now has confidence in the plan, and that you're continuing to work with our persistent partners for its delivery.
Okay, thank you, Ben. And I know you were at our last group board meeting, and the winter plan, we had quite an extensive dialogue about it, and at that point had deferred signing off the winter plan and delegated the conversation to the quality committee, which did take place. Is this something you were going to pick up in your chief exec's report, or shall we respond to Ben now?
Probably going to we can respond now. I would say, and it's an ongoing assurance process. Obviously we have industrial action coming up, and we don't know whether that will continue through the winter, but we certainly have worked with our system partners about putting in place the additional capacity that we feel we would need in our worst case scenario, and that has been agreed. We are also in a slightly better position in terms of escalation currently across the hospitals, although I do note NVT at its highest ever attendance yesterday, again rather unpredictably. So whilst we can never, I would not want to be the one that said it's 100% assurance, I think we are as close as we can possibly get given the circumstance, but it comes up regularly at the ICB board, it comes up in this whole range of meetings we have, PEMS and POMS and all sorts of things, so it's being reviewed on at least a weekly basis. If there's any change to that, they will be letting the board know.
Thank you.
Okay. Does that help?
That's very helpful, thank you.
Any other points from members of the gallery there? No? Okay, thank you. So we'll move on then to the chair's report, which I will take largely as read, and as usual, the two vice chairs have also reported their activity here. So continuing to be visible internally, visited lots of services, including the SDEC at Weston and the opening of that, which was great to see. It's a wonderful new facility and is going to make a huge difference to local people. The 3D Medical Centre was inspiring. The extent of the innovation and technology in 3D printing kind of body parts and faces, and it was an amazing thing to see, and very inspiring that we're able to restore people in the way that we are through that service. Dermatology was a fascinating visit as well, because they work both within the hospital but also teledermatology in Cosham and in other community venues as well. So that was a very interesting visit. I met with Sophie Gretton, who's one of our end-of-life palliative care consultants, who was telling me about the HIT research project, which is very much about co-production with other providers, with people in communities we serve, to create new ways of working around end-of-life care. Lisa Galvani is the Divisional Director for Medicine, but I met with her because she has recently been elected as the co-chair of South Bristol Locality Partnership, which is fantastic. And she was telling me about that project. Some of us will be hearing from her later today when we're talking about neighbourhood working. But of course, South Bristol is one of two neighbourhoods which are national pilots now within our patch. So that was really interesting. MBT Awards, fantastic evening. Thank you, Elliot, to the team around comms that organised that. It was great fun as well as being inspiring, so appreciate that. Continuing to meet with partners. The Community Participation Group has had its second meeting. Steve and I were delighted to be part of that. It's really beginning to come together now in terms of getting to know each other, establishing ways of working, beginning to shape up an agenda of what would progress look like, what would count as success in relation to co-producing with them elements of the joint clinical strategy as we refresh it and roll it out. And of course, we did have the big event, partnership event around the joint clinical strategy with, I don't know, about 150 people, something like that, from a very wide range of organisations, people with lived experience as well. So that was a really excellent event. Glyn and I went to visit RP Health and one of its community health clinics. So much to learn from that around making services accessible, trusted, in locations that people know and delivered by people who look like them, actually, and, you know, overcoming language barriers and all of that kind of thing as well. So it was a really inspiring visit, wasn't it, Glyn? And I think there's, as I say, a lot of learning to be taken from that. I was also really pleased to go to a children's hospice called Jessie May, and delighted to learn that we have a really strong partnership with them. We actually employ their nurses through UHBW Children's Hospital, and although they work for Jessie May, and there's a fabulous ongoing partnership there. And also I was delighted to be at the Bristol and Weston Charity Strategy launch, which last time had to be deferred, sadly, but this time went really brilliantly. Lots of support there, and hopefully the launch will have re-energised some of their fundraising activities as well. Nationally, I was invited to be a part of four of us went from NHS providers to give evidence to the Senior Salaries Review Body on very senior managers' pay. which was a fascinating experience. I've never been to a review body like that before, but we took a lot of evidence that had been gathered from NHS providers membership and gave written evidence as well as verbal evidence to that, which will be being published. And then finally, it isn't in the report, I don't know why I overlooked it, I am continuing to be part of the National Learning Set for Group Chairs, which last time was focusing particularly on integrated health organisations and what that might mean. So I think that's enough from me. I will hand over to Sarah and Martin if they wish to highlight anything from their areas of the report. Otherwise, for information colleagues, anything you want to pick out particularly?
Not. So, I think the only thing I would highlight is the UHBW Research Showcase, which was a great event, and fantastic to see so many colleagues engaged in research, in part supported by the charities that we have in the hospitals, and also, of course, some very large external grants as well.
Great, thank you, Sarah. So the report is for information, but I'm sure we'd be happy to pick up any points that anybody would like to pursue. No? Okay, thank you. 15 minutes till 11 o'clock, Maria.
Yes.
So let's make a start on your
Looking
report.
at my cut-off point. So please stop me if we get to there. But I'm going to try and take as much of the report as read. In October, there was a government announcement about review of anti-Semitism and racism in the health service. We will be aligning with our ICB on the statement. I know there have been a number of statements coming out, both at citywide level and some conversations nationally, but we will be aligning with our ICB to make that statement. And in fact, both Mark and I were at a race and health equity event yesterday, and I think it's fair to say the strength of feeling around supporting our global majority colleagues perhaps more effectively, both as patients, staff and local residents, was made very clear. We particularly focused on research and some of the health inequity around deprivation and disadvantage, and how things are compounded actually around intersectionality. So obviously we will want to do a lot more work in that space. Medium-term planning framework came out. You've got a little snapshot of the areas that we're looking at. It's a multi-year framework, which is a new thing, which is good. What we don't know is the payment mechanism around some of this. So what will be incentivised and potentially what could be some of the risks in moving out of what has become a block contract generally into a more activity-based contract. So that will be work that's going on over the next 3 years as part of the settlement. You'll note some very stretching targets. By the end of the period, an 85% 4-hour target for ED, some handover targets and response times for ambulances. There is already a timely handover programme, which is having some impact, I think we can safely say, in our ED departments, where handover is in fact very timely and ambulances turn around very, very quickly, perhaps without the usual full protocols that we have employed previously. So that is something fairly new that we are working out how best to ensure we don't have extra surges going on in the departments. A couple of other things. People are aware, but this is just for formal noting, that we have a cluster of our own ICB now with Gloucestershire, and the 2 appointments that have been confirmed are the Chair of REFARA and the Chief Executive, Shane Devlin, who will move on to the next stage now of pulling together their combined team. And I think a consultation on that will be underway fairly soon. I will leave the operational pressures for the HMDs to pick up later in reports, but we acknowledge the increasing attendance in both hospitals. We are due to have industrial action starting on the 14th for a 5-day period for resident doctors. There is a 10-point plan that has come out with Magana as CMO. Has written out to everyone about what we can do, certainly in the non-pay environment, and we are working through these locally with our resident doctors, and there is a meeting arranged across both trusts. We have got an action plan against each of these points, but we'll continue to work with our doctors about what would make the difference. But obviously this is a government and national conversation ongoing. Partnership events being mentioned. Just want to say how grateful I am too for everyone who came along. Really, really good feedback and lots of next step intelligence for really accelerating the joint clinical strategy. And I'm sure, Tim, you were very pleased at some of the inputs we got, albeit AI generated at the end, but they were very powerful summary of where we need to focus our efforts. Interestingly, given Sarah's presentation to us this morning, we have been doing a lot in the mental health space. Our own liaison psychiatry teams have both been reaccredited and are working together as one of our next group services. At our joint senior leadership meeting, we had a big session on anti-racism and trauma-informed care, recognising that racism is a form of multiple trauma on an ongoing basis and how our staff respond to that in a sensitive way. And then just lastly, acknowledging MBT Finance of the Finance Team of the Year, the Stroke team as well, have all done very well in their improvement efforts. We took Damien Egan MP for Bristol North East out to Cosham. Damien, who is obviously the local MP out there, had lots of questions about the future of Cosham. We were able to show him the full range of services there, from diagnostics in terms of MRI, CT, our antenatal, postnatal care, the therapies we offer there, and dialysis, of course, big dialysis centre, with a view to putting more services on that site. But we also talked him through, Steve and I, the outcome of some of the maternity work that's gone on nationally, our changing demographic in terms of population and safe delivery for our local women, and the fact that actually being near a hospital environment is a much safer environment, given that caesarean rates have gone up so much in recent years. So I think that's probably all I want to say, but very happy to take questions.
Okay, thank you, Maria. Any points people would like to follow through on? Mark?
Just a very minor one. Thank you, Maria, for your report. Really helpful. 3.1, operational pressures and urgent emergency care. I'm just wondering about the kind of impact on kind of staff and who are in those pressurized areas, and where we've got the kind of the intelligence to know how they're feeling, how they're getting on, their resilience, their any kind of like tracking the sickness. Or I'm just struck by the words that you put in your report. So
well, I think we would have to acknowledge that having to use escalation space, some of those pressures, bottlenecks, really does have an impact on staff, because they know they're not able to fully deliver the care they want to, and that they are compromised in some respects, whilst trying to do the very best they can with the space they have. We have some fantastic leaders who are down there supporting them all day, every day. Some great initiatives going on through our HR and OD teams. If any of you get a chance to pop down and say hello and thank you and acknowledge, I'm sure that would be grateful. I personally, I know much of the team go down very regularly to see the ED team and see what they're coping with. I would add, that the timely handover programme is having quite an impact. So just trying to support and acknowledge what they're having to cope with, to play our part in the system. But actually, we also require the same response from our system partners. I definitely would acknowledge we've had great support right across the system, and in particular around some of the difficult critical incidents we have recently. System partners have really stepped in, so I would want to acknowledge that.
Thank you, Maria.
Roy?
Thank you, Chair. Firstly, congratulations to the finance team for meeting finance team for reaching the HFMA for the award, and I can few of them have a self-award. It's good to celebrate, so well done, PT. I've a question on 4.2, Maria, the joint senior leadership meeting with Peter Landstrom. There was any sort of nuggets that came out of that where you did work and we haven't thought about that, or
Well, I can't tell you the Chatham House bits. I would say Pete gave us very much a warts and all talk through the journey. But actually, it was really, I think, very interesting the way they have looked at their clinical divisions. So across the group, they've looked at a kind of clinical oversight rather than group managed services, which has been very interesting. They are, I think, in terms of their framework, they went through a much longer journey as they acquired hospitals. So the most recent North Middlesex was really only in the last 6 months. That's been a conversation that's been going on for nearly a decade. I think there was also acknowledgement that even as a group and a set of organisations, they've all retained their own personality, they've all retained their own great legacy, and they've been working on a strengths-based way using the best of all. But it seemed like they were in a good place. I don't know what anyone else, all the other execs who were there, any thoughts or reflections you had from Pete?
Jenny would like to speak.
So I think it was really helpful that Pete came, and it also dovetailed with several of us going to the Association of Group meeting where I met his chief people officer. So I just think that the benefit of the sharing of experience, I felt sort of confident following that to be able to reach out to Thomas Pound, his CPO, to say, I'm thinking about, are you a few steps ahead, or what's your learning around it? So I think it was hugely helpful from that sort of broader networking perspective as well.
Yeah, I mean, I know we've said it many times, but, if you see one group, you see one group.
Yeah.
They are all different, forming in very different ways for very different reasons with very different bandwidth hours. One thing Pete did say is he thought we'd done it exactly the right way with the joint clinical strategy, that they've actually gone back and done the joint clinical strategy almost to get themselves again in the right place to move forward. So we seem to have done it the right way. So it was mutual, actually. He had quite a lot of questions for us, and we are learning together. Association of groups, being there at the forefront of others who are trying to do the same thing in lots of different ways, has been very helpful, and hopefully learning from one another's mistakes and successes.
Now it is nearly 11 o'clock. Do you want to just ask the question, Martin? We'll probably have to save the reply to that.
Yeah, it wasn't really a question. I was just going to say, in response, I've been to all 3 EDs in the past month, and I have to say people were really positive. And even though with the transfer hospital protocol, I was specifically asking about and queuing, everybody thought it was really the right thing to do, even though it did bring pressure into the hospital. So even sort of positivity about that. Yes, it's difficult for us, but it's better for the ambulances to be on the road.
Right.
So good luck. Came away feeling very positive about those visits.
That's good feedback. Thank you. So, colleagues, shall we pause for 2 minutes? And I'd invite you, if you're comfortable, to stand as we remember all who've served and sacrificed for our freedom. We will remember them. Thank you, colleagues. Okay. I don't know if there were any other points to pursue from Maria's report. Okay, in which case let's move on to the merger update. I'm not sure, Maria, is it because Paul is not here?
No, we've got Rob.
Completely sure.
Yeah.
Oh, Rob, welcome. Hi. Would you like to introduce yourself? You won't know all of us. So.
No, hi. I've recently joined the Trust. I'm Rob Gittins. I'm the Group PMO and Merger Programme Director.
Would you like to come and join us at the table? Be easier to interact and hear. Welcome.
This is a report for noting, just outlining the efforts we've been taking and making to move forward. Just reminding everybody, of course, that our merger has been deemed the best means to deliver the group benefits. It's not a destination in itself. It's merely a build on the work we've been doing, all of which has been essential work in any case, to allow us, given our clinicians' feedback, to be able to both accelerate pace, deduplicate further, make life less complex, and allow us to hopefully move resources round in a less clunky way as we go forward. So you will see that we have we've already submitted one of our strategic cases and had approval with our amber rating. We're now proceeding under section 56A to ensure we've got the right level of governance. We have the due diligence underway, which is actually a rather complicated and lengthy process, which is absolutely right, and we've established some governance around that with the programme board and the statutory merger committees in place, and we have a comms and engagement plan. This is around our 4 Ps, and that the project team are ensuring that we embed this with our staff as well, with the OD and culture plan. Obviously, as we go through a lot of the work, we are looking for opportunities to connect with people and explain what we're doing. But again, I go back to the fact that the merger is a means of being able to deliver things more effectively and ensure we do get the full benefits out of the case that we're putting forward. Also, just to say, we did have our first evaluation meeting last week with Health Innovation West of England. I don't know if you were there, Mark. Which was, I don't know if there's anything you want to say, but again, we are one of the first to do this, and I think it's a really positive meeting. What we're doing is, whilst we're looking in particularly at cardiovascular, a lot of it is about the learning and how quickly we can adopt that innovation, different ways of doing things, and then how we ensure we track at 1, 2 and 10 years. Is that about it?
Yeah, just to say that I personally found it really refreshing, the approach, bringing in the local health innovation network. Not everyone does this, and their purpose as a commissioned organisation for this is to provide an element of impartiality, also to work with Paula Clark as the lead person doing this, the sponsor, and really think about innovative models of evaluation of where we've got to and how we've got there, and what are some of the learnings we can take from this and take it into other elements of our work from joint clinical strategy work. It felt right, it felt impartial, and it felt that we were doing it from the purpose of trying to really think about what can we learn from this to go forward in the future as well. So yeah, really first meeting in, but it felt very kind of strong and powerful.
And we obviously had a session with our senior leadership team. There are ongoing internal communications, and the team are meeting very regularly with our regional colleagues who are supporting us going forward. I might hand over to Rob if there was any further detail you wanted to bring into the preparatory work we've been doing.
No, I think you'll have read the paper. We're going through there's a standard process of review and approval, and we're working our way through that against a target date of summer 2026. So we're just finalising dates with NHS around their review process, but it's looking we're very much on a firm trajectory now towards the summer of next year around merger. What I would say is Paula and myself previously worked together on the merger for Western District General and UHB hospitals, so we're bringing the learning from that process through into the exploration of merger of NBT and UHB.
Okay, thank you. Any thoughts, colleagues, on this update? Martin and then Linda.
Yeah, just I'm totally content with the update, the timeline, but as it becomes more, I suppose, factual, it does make me think there's a lot of work to be done out in the organisation. And I suppose the more we move from theory into practice, maybe it's the PTIP, I'm not sure. I just worry we need to make sure we take into account the workload of people who are going to have to deliver, particularly, I know some of it may come after merger, some of it before, but winter, difficult times, new plans for next year, extensive, national targets, etc. We haven't got a lot of resource actually to back this up in terms of extra people. So a lot of it, I guess, is falling on people who are also doing other existing jobs. So, supportive of it, brilliant. And, we have done I was saying we did the Western, and it actually took a long time post-transaction to bring everything together. So I suppose that's the key, isn't it? It's how do we plan that stage of getting to full integration, as it were, rather than just ticking the box of merger, perhaps. I don't know.
And Linda?
So I was going to ask two questions. One was very much just what Martin has raised. The second was, I'm heartened to see in the paper that there is a comms and engagement plan, but it's something we've been asking for line of sight at board for some time, and we still haven't seen it yet. Elliot, will you be covering that in your update? Because I noticed it was just a verbal update you're giving, so it's hard to know if you're reconciling the two.
So I can absolutely cover what we're doing from a comms and engagement perspective. It's the full document's about 50 pages, but yes, I'll happily cover that.
That would be great. And I think the other thing that we benefit from is just, what's the elevator statement? What's the pitch? If I get stuck on a lift with someone tomorrow and they say, what are you doing and why are you doing it? It'd be really good to have that as a consistent, well-established message.
So we've absolutely got an elevator pitch. I'm
Have you?
happy to share it.
Okay. See it.
Okay, thank you. I don't think everybody in the room has yet seen the communications draft, so we need to have a conversation about that, I think, at some point very soon. The thing is in 3 T's, isn't it? So we're doing the transaction, then we have to make the transition into a new integrated organisation, and in doing all of that, it's all about transformation. And therefore the OD and culture plan, Jenny, is utterly crucial to this, isn't it? And I note that it's coming to board in January, but we're really going to have to get our skates on then, because the thing absolutely will stand and fall on culture. And also evidence demonstrates, to Martin's point, actually many mergers do not drive out the proposed benefits. So the implementation plan, the delivery plan of those benefits is also absolutely key to the success. Richard.
I guess with my audit chair hat on, for me it's risk. And are there any risks coming out of the actual transaction or the transformation plan which need to make their way onto our risk register? Because we kind of need to see those coming onto the register really before the end of this financial year, so we can take them into account for next year. At the moment, I don't see them.
Okay.
I mean, there is a risk register, isn't there, sitting with the plan?
That's correct, yeah. So the due diligence highlighted across all our domains the relative risks associated both with merger and also the transaction of merger. And those have been translated into a merger and risk register, and that's being the individual sections are being managed through the merger work streams. And where those are additional to the existing corporate risk register, they'll be escalated up through the normal channels to either to the BAF or to the risk register.
So what I'm saying is that escalation process needs to arrive at the BAF and then feed into our plans for next year in terms of internal audit programs, really by next February.
Yeah.
Which is quite a short time scale.
Yeah, and I'm sure duly noted, Xavier, yes.
Well,
Do you want to comment?
If I take an action on the board action tracker with Rob to make sure that there is at the next merger programme board a specific conversation about whether any of those due diligence risks escalate onto either the trust level risk register and or corporate risk register between the two organisations, I'm happy to do that.
Okay, great.
It will be
Thanks,
a conversation
Xavier.
open to our private session around Sunday night of the week.
Yeah, so there is further conversation later on exactly this. Neil?
Thank you. I mean, I see the transaction risks describing how we get through that process, but I think when we do the post-transaction implementation plan, that's where really all the work sits to turn two organisations into a single organisation, aligning the way we work and the things we use to do our jobs. I think that's where we have the development of the implementation plan with the risks that come around, how long that will take us, how quickly can we go, what order do we do things in. I think that's where we get into that level of discussion. So I think the PTIP as described here is a very, very important part of the process post the transaction.
Absolutely. Jenny?
I was just going to update really on the Odeon culture plan. So I'm working with the team at the minute on its component parts, and what's really stark is that we are already doing an awful lot, because as Maria describes, the merger is to drive out the benefits of all of the work that we are already doing, which is led by the clinical strategy, and therefore the work that we are doing to deduplicate the provision around those pathways, as well as the corporate services changes. So there is a huge amount of OD work already happening in both of those programs, which I'm getting them to document in order that is just visible, and then layering on top. So what is it specifically that the merger is going to require us to do through the lens of OD and culture? There's a couple of key decisions for us to take in there about what we prioritise pre and post merger. That's just the piece that I'll need to take through the necessary decision-making processes, but we've got a firm view on what we think those are. So the paper will be coming to the merger board in December, which is why it just flows then through into governance in the new year. But the team are well on with it, and actually I'm really pleasantly surprised by the level of work that is already underway. We just need to be able to make it very visible for you and augment it with and what more. I think the piece that will be really important for us will be our staff survey results that we get at Christmas. I think that will also just be a very important temperature check for us about where staff in both organisations are at. So we'll layer that in to an iteration.
Thanks for the update, Jenny. That's good to know. Okay, I'm not seeing any other hands, and the paper is for information and to note the updates on progress on the merger programme. So I think with that, we will move on to hear about the innovation strategies. So Tim, I think, are you being joined by colleagues?
There were two colleagues.
So I think Tim, Kathy and Rosie may be joining us.
We'll just allow them to find a seat.
Hello and welcome. Right, come and join us. Tim, what should we arrange people?
Yeah, that's maybe do you want to come towards the front, so there's some seats there.
Table or table.
Yes. One here.
Especially you, Tim.
So if we get started, thanks for going to join us. Our guests, I think there was a change of timing, so that's might have been some confusion with timing. Apologies. If I introduce the topic, I'll let my colleagues introduce themselves, and then I think we've got a few slides as well. So, innovation. So there is, if you haven't noticed already, there is an I in my title, and innovation is a pretty difficult word. It is quite loaded as a concept. It's exciting. Innovation, it sort of has visions of something futuristic and trendy. It's pretty impossible to define, and it doesn't matter what program you put innovation in, you are guaranteed to get very different definitions of it churning out of the machine. And of course, there's also a sort of FOMO associated with innovation, is that we somehow have to be doing it, otherwise we're missing a big prize. So we have tried to pull together what we think innovation can mean for our group, and what the benefits should be, and how to drive those benefits, which are referenced in the group formation business case. I think it's really important, and it has taken us some time to reach this point. It is really important to say what innovation is not, according to our definition, that innovation is not research and development. Okay, R&D is a very separate function. We spent some time trying to think about whether to pull that together, as other organisations might have tried to do. And we are very clear that we should keep distinct research and development from innovation. So the two teams and two functions are very different. Notwithstanding that some innovation projects will be fueled by research and development. Innovation is not international health. And this took me off a sort of slight tangent for a while, trying to define what we mean by our international health program, which is developing alongside our innovation ideas. International health is largely around education, some commercial opportunities, health tourism, and supporting less privileged organisations around the world. Again, notwithstanding that some of our innovation will have an international flavour. And finally, and this was a very recent revelation, innovation is not improvement. And the two functions are very different. Notwithstanding that at some point, successful innovation will transition into an improvement programme in order to drive the benefits. What innovation does have very clearly in every healthcare organisation is a very close link to commercial opportunities, and something that we are actively pursuing with Neil is to drive the description of our commercial function as a group and to understand the overlap between innovation and commercial. And also what innovation does have is very, very strong foundations in the joint clinical strategy. So broadly speaking, we've engaged with lots of different staff members and also lots of other organisations and partners, university partners sat around the table, for example, very strong innovation cultures in both universities. And we've defined that there are 3 themes or 3 USPs which we can offer as a Bristol NHS group. We certainly have a background in homegrown innovation. So we are full in our 50,000 staff group, we are full of people who've got bright ideas, and some of them we let them develop those ideas on their own. Sometimes we try to give them support, and very often we tell them that we can't help them, and it really has a negative impact on them. But for example, in terms of case studies, people in our organisation developed a patient-centred app, which was to allow patients to communicate with their relatives 24 hours a day in real time, so the relatives could get updates on their care instead of ringing the nurse receptionist on the ward. That app is now called Clara, and that app is now valued at £2.3 million. We missed out on that return of investment. That was homegrown innovation. That was 2 junior doctors and a nurse who were working in Bristol who developed it and trialled it in our patients and on our wards. The second pocket of USP is partnerships. So between the University of Bristol and the University of West of England, we could not be in a better position to partner with academic institutions, but also with industry. You'll know that Bristol and Western is known as the Silicon Valley of Europe, and it really is. And every week we scratch the surface and we find that there is an incredible amount of digital technology, robotic and mechanical engineering happening within 20 miles of where we are sat today. And the third is actually a little bit simpler, and it's about adoption of existing technology. So we know we have a massive patient diaspora, we have a big workforce, we have a lot of estates, and we do everything in this group. There is no specialist service that we cannot offer. And so as a centre for adoption of ready-made off-the-shelf technology, innovative ideas and other bright ideas, we are a fantastic test bed. So what do we want to do? Broadly speaking, we want to enhance the culture of innovation and curiosity. We want to enhance the feeling of permission and permissiveness, to give people the feeling that they can develop ideas here and introduce ideas here. And I want to avoid the constant barrage of emails that I get, and I'm sure some of you get, from people who work here that says we just simply can't do it. The organisation says no. So we need to engineer that culture out. Very importantly, we need to provide a framework and a prioritisation platform, loosely called an innovation hub, which will allow us to harness as many ideas as possible, and for us to check and challenge those ideas against an ethical framework, a digital framework, a commercial and financial framework, and a clinical prioritisation, in order for us to know which of those ideas we wish to sponsor, we wish to mentor, and we need to support, perhaps with financial assistance. And then very finally, projects and innovations that are bearing fruit. We need to make sure we don't lose the return on investment. That means we do have to get smart here, and we do have to create our own intellectual property, our own commercial frameworks, our own legal and business frameworks, which means that people can feel as if they can innovate, not to lose control of their idea or their hard work, but that we collectively can share the benefit. We are building you up month by month to an innovation strategy which we will launch in March 2026. And along the way, you will have the ability to see some of our business cases, which will require your support in order for us to bear fruit from our innovation strategy. I'll hand over to my colleagues.
Okay, so Tim said a lot, I think, of what we were going to say. That's absolutely fine. But we did think it would be helpful to bring to life a couple of areas that we've been working on. So we've been working over the last 15 months together, and that's been, I suppose, something that's a bit different, working as two trusts together to design what our innovation offer could look like, what our framework looks like. And we've done this based on the feedback that we've got from people saying, what are the barriers to innovation? So what we've been trying to do is really look at what we can do to address those, not just what we do within the trust, but with the partnerships that we have outside of the trust as well. And we've, some obvious ones there of the universities, but also with our innovation community in Bristol, which is actually really strong and we don't tap into particularly effectively at the moment. And if we're talking about, commercialisation opportunities for that, then that is, one of the areas that we really need to be going to. But to be able to do that, we need to get our house in order and have the framework. So we've all... Wait, no, gone the wrong way. That's not a good start, is it?
Does everybody know who...
Sorry, shall I just introduce myself? Sorry, I launched straight in there. So I'm Kathy Capel. I'm the Deputy Director of Improvement and Innovation at UHBW.
I'm Rosie Gregory. I'm an improvement partner in Kathy's team supporting the innovation work.
And I'm Tim Keane, Associate Director of Strategy at North Bristol in Taylor's function.
Right, thank you. So we started with the premise that we're open for innovation, and that's what we want to be. And I'm going to trademark this with Sarah Dodds, who actually came up with this phrase. But I think it's really nice and tells our staff what we really want to do. I'm not going through all of the slides, but what we've been doing over the last 15 months is looking at how we can support innovators at all stages of this innovation spiral that you can actually see if you've got the slides there. So it goes from having an idea, an opportunity, thinking what the challenges are, developing innovations, all through to growing and scaling them. And that's what we've been really testing out over the last 15 months. And as Tim described, there's a real opportunity on the delivering and implementing and the growing and scaling steps to include improvement methodology to actually really start to embed some of the really successful innovations in our organisation, be they homegrown or be they coming from elsewhere that have been proven to work. So this is what broadly the framework will do, and we've put together this as a bit more of a schematic around what we've actually been testing through for the last 15 months. So we've set up an innovation support group. Initially, we started that at UHBW to get going, and then Tim has joined us in the last 6 months to look at the innovations coming through from both trusts' point of view. And it's about wrapping support around innovators, as I say, at whatever stage they're in of their innovation. And we want to give you an example of something that we're currently live and working with, which is called Rate My Shift. So if I hand over to Rosie to describe.
Yeah, so Rate My Shift was developed by a sister within UHBW. She's a co-founder with another nurse down in Taunton. And they've commercialised originally an improvement project into an app which looks at staff sentiment on wards. So at the end of their shift, they rate it with a coloured smiley face just to say how they are. And that then leads to a conversation with their manager if they've had a bad shift to understand why that was, and to start building that culture of talking about how things have gone and how we can improve it. And we, as an innovation support group, have helped to leverage a ward for this pilot to go ahead on. Sarah Dodds has now agreed to be the SRO for that project. We've brought the Health Innovation Network on board to support the real world evaluation and their independent evaluation partner. And we've worked with our digital colleagues to make sure that we are compliant with all of the digital requirements, any IG requirements. So we brought together lots of different parties and acted as that super connector in the middle to ensure that everything is met appropriately.
Oh, they won an award recently.
And they've won an award. They won a Nursing Times Award in the last couple of weeks as well, which is amazing.
Okay. So, done it again. So really it's about, that's a relatively small scale innovation. But actually what we've been able to do is really accelerate for our two innovators, how they can actually start to do that real world testing. But we can apply the principles to innovations of various scales, and be they clinical or non-clinical innovations. And I think that's really important because we really are open for innovation across all of our staff. It's worth just talking a little bit as well, I think, about the sort of the commercial business side of it, Tim.
Yeah, so Tim mentioned the Clara, which is this patient communications innovation which two of our junior doctors developed. So we did test that on in a ward back in March for 3 weeks. But really positive feedback. We had it evaluated independently the Health Innovation Network. They're keen for investment. They were keen for us to be a partner, an equity partner with that product. And unfortunately, we haven't been able to progress that yet. But what we're seeing there is that this idea is really great, but it's a long journey to get this through to be deployed widely across the NHS. So some of the barriers include integration with clinical information systems, and we know there's sort of two-year timeline to get that in place with sort of Careflow at the moment. So yeah, huge amount of opportunity and innovations coming forward. We know that innovation worked, and the appetite to work with us was there, but we just didn't have the infrastructure or the policies in place to be able to make that happen. So that's what we're trying to address with this innovation hub.
Yeah. So I hope that just brings a little bit to life for you, showing what we've been able to do with, bits of our time to start to really build our innovation offer. Obviously, we want to scale that up now and be able to really go out to our staff and externally to say, bring your ideas. And you can see up in the two bubbles there, it's our staff bringing ad hoc ideas, but we also want to, where we've got a particular problem, and Tim gave a good example this morning, you will have heard this morning about the cancer waiting times. In fact, only 3 trusts are apparently meeting the 62-day target. And actually, could we put a call out both to our staff and also externally to say, come and help us if you've got ideas, innovative ideas that could help us fix that. We need the framework to be able to support that, and that's what this will do. But that's the sort of thing that we're thinking about how we develop going forward. So I'll open it up now. I'm sure you've all got comments, thoughts and questions around what we've been doing so far.
That's great, and great to hear some really practical examples of innovation actually happening in the two trusts. So thank you for that. Mark?
Yeah, I can't quite contain my excitement. Sorry, you probably saw the expression on my face. I think this is amazing. I think this is fantastic, and it's just the direction of travel, I think, for the group now as well, in terms of the word innovation has worried me, I think, in terms of where is it, what's going on. I know we talk about it, and Tim says it's really hard to put your hands on it sometimes, but just the stats, 28,500 kind of employees, multi-billion pound organisation. Some of the hardest barriers of people finding to bring their products to market to actually help people is because of how the NHS is as a system. This organisation has the ingredients to actually help that happen, whether you're a budding inventor looking to do some small diagnostic tool, or someone that's trying to break through in terms of working with other people. I shan't hog the time, and there's so much that I've written down on this as you were speaking, but it's so powerful because at the heart of this actually, and this hasn't been said, is the phrase social innovation, which means that we take what we do, and there's a lot been written on this in terms of the whole, what is meant by social innovation. What it ultimately means, as I understand it, is whatever you do in the innovation space reaches the people that needs it the most or need it the most. But it goes back to the underrepresented communities, those underserved communities, and those where challenges exist. If you can do that through technology or otherwise, then that's a great win. There's something for me, I think, about how we do then connect through with the likes of the Health Innovation Network. I think that's crucial. I don't know if you mentioned already, it makes absolute sense. The universities, whether it's SETSWED, whether it's Futures Space or Futures West or WECA, there absolutely is. This is about commercialization as well. I know that might find a bit uncomfortable for some people, but ultimately, this organization is peppered with innovation throughout. And again, I go back to, it's frustrating to hear when there's a loss of potential IP or income because we didn't act quick enough, or we didn't get our house in order, or we didn't have a bit of money to put into an equity share program whereby we could have got something from it. That to me doesn't feel right. So absolutely, I think this is about the growing emergence of the group structure to do something through the innovation for stamp. My only question would be, do you want to put the word enterprise in there as well? Because actually a lot of innovation leads to amazing enterprise. I'll stop there because you contain myself, I appreciate it. But well done, seriously. Brilliant start, brilliant work.
Thank you, thank you, Mark. Roy and Maria, do you want to come in too?
Thank you, Chair. I'm also very excited about this. Not probably as excited as Mark, but this is fantastic and well done, and I'm a huge supporter of the work that you're doing. The thought in my mind is really speed, because Tim, you mentioned missing out, but you mentioned you're doing bits and pieces of it, and I see in the timeline, we've got April 2026 for the innovation team to be started. I guess the question in my mind is, what is preventing us from being able to have people dedicated now to drive this faster, further, and not having to do with whatever we've got? Again, we're a multi-billion-pound organisation, and the board has been clear about our risk appetite in being able to push this agenda forward, or what's stopping us from funding the right team now.
So I was hoping someone would answer that question. So there's a business case. I'm sorry to talk in business case language, but we do have to fund people to do this. This is not part-time, as you know, Roy. This people who do this in their spare time. That's not going to work. So we are bringing a business case, and it is in December, which is a few weeks' time. And if that is successful, then we will be able to proceed to build that team very quickly.
Where do we help, Tim?
So I think that we need to. There's a process for having the business case. I think there will be checks and challenges. So I think let's bring that business case through the business case channels and ensure that the funds are there or earmarked for this adventure.
I too am very excited. The ability to adopt and spread at pace and get the return on investment using commercial, non-commercial income is absolutely what we should be doing. Our staff really get very excited about this as well. So it's an energy giver. Sometimes, so Tim, you took a while to deconstruct what isn't innovation. That presents a bit of a barrier, I think. And as we look at the environment that supports some of this, there are a dizzying and quite complex array of organisations out there, from Health Innovation to the Applied Research Council to NIHR to Bristol Health Partners. It's quite hard to know where to go to frankly get the best bang for your buck and to get the right support next to what you're trying to do. At regional level, or even with our university partners, is there anything that could make that easier? Because but by the time you jumped through and used all your thinking space for which organisation you should tap into, you've probably lost a lot of your energy.
Is that a question? Is that a question for us? So I completely agree. I think it's dizzying, really. And what I think the deconstruction part is to is hopefully we don't get the impression that we're not open for that altogether. We're open for it all.
Yeah.
I think the deconstruction is about our internal framework to manage that. So when we get as colleagues will know, conversations with hospitals in a foreign country who want to do something with us, it's quite hard to navigate them through. So we want to have clear routes of navigation for international health research and innovation. I think, I'm conscious that this will be on the public record, but I do think we have developed in this region particularly a new number of organisations with overlapping functions, and I think it is always useful for us to step back with those organisations and check and challenge that we are not duplicating work. Is that fair, Mark?
I'd concur with that, Tim. I think it's time because of the intersection of not just what we're talking about here, but also the economic needs of the region and bringing people into good health, if they're not already, so they can contribute towards the economy in whichever way. And that comes through an innovative mindset. So I completely co-share with you.
And if I just finish one, so we know they're successful. If we talk to London, I know we're talking to Ian Abslotter today about this, and they have been very successful in their ventures in London, the Northern Care Alliance as well, very successfully in this. The key thing that they tell us is it is complex. There are lots of competing organisations, but the thing which is always the winner is the collaboration between the healthcare organisation and the academic partners. That has got to be the driving force, because that combined power was huge. And whether you're talking to a small developer or a large investor, they will really recognise that partnership between the healthcare deliverer and the life science or academic partner. So that's our first partnership.
It's nearly time for a break, but I know Neil wanted to come in, so last word, Neil.
Thanks. But just important to see the business case in the context of the wider group benefit case and transitional investment requirements that was set out. So I think what Tim's described for innovation will be true of commercial strategy, true of sustainability as well, and that the need to pump prime these investments, but with some indication in terms of the expected return over what period of time. So I think the change maybe with the approach in the past is quite often we'd have these kind of ideas competing in an annual business planning round, competing against safety in clinical areas, whereas now under transitional investment we're willing to take up that risk appetite in terms of investment over a longer time frame.
Can I just say though, just hang on to the social innovation piece, because sometimes that doesn't get measured in pounds and pence. That get measured in outcomes to families and environments where the care is provided in a different. So we in my opinion would be, we don't lose sight of that personally. But I do agree with you, Neil. But
Linda.
Finally, I know we're coming up to break,
Finally,
but I just wanted to add, I think as well we shouldn't lose sight of, in fact we probably could make more of, the potential impact of this on our staff, on our brand, on our ability to attract and retain talent. This is really exciting. It's really different. We have a USP, we have a track record. I think we can do something really special here. But if we think about the day-to-day impact this would have on people in terms of the new culture we're trying to create, the new group model, aligned with the external view of us as a trust, I think we just need to make sure that that thread gets pulled in as well, because it's absolutely fantastic. Almost as exciting as me.
So, thank you. I think you will have detected the degree of support and enthusiasm for the work you're doing. It's really great to hear about it. I can see that we're going to hear, this is a staging post, I think. It's been an initial conversation around the board table with a view to hearing back from you in March with the formal group strategy for us to consider in this area. And we're being asked to discuss and endorse the strategic direction and principles, which I think we can full-heartedly do, can we not? Yeah. I must say I was delighted, Tim, by your deconstruction, because, what we're looking for here is often a paradigm shift. So it's not polishing the candle to get a light bulb, is it? So more light bulbs. Great. Love it. Thank you. And with that, we will pause for 10 minutes break. Thank you. Right. Okay, let's make a start then. So group approach to anti-racism. I'm going to hand over to Jenny to lead this item.
Yeah.
Thanks, Jenny.
So, delighted to be able to present this, and I was really struck by how different the approach is to what I've seen taken in other parts of the NHS, and how strong I think the team have researched and considered just how we take this really important topic forward. So this is all work pre-me. It's just a delight to be able to present it, really. So I'll take us back to August 24, where I think MBT and UHBW had a joint board-to-board discussion, which raised the profile of and commitment to, and the need to do something very specific regarding racism. And in November 24, we just brought together some immediate plans together in response to that. But a lot of those things were things that many of the rest of the NHS were doing. And it was recognised that actually we needed some sort of framework and a structured approach in order to make sure that we really were going to turn the dial on this topic. Because I think the bit that we are all struggling with is there's a lot of goodwill, but actually whether you see anything realistically change over the decades that we have all been trying to grapple with this, there's little evidence to show that things are genuinely improving for people of colour. So I'm delighted with the approach that the team of sort of are recommending in this paper. I've not yet been able to research whether this is one of a first, but it will, it's something I'd like to check out. Most organisations are focused on the NHS high impact actions, the 6 of them, but they are quite transactional. They're important and they actually feature in our plan, but the proposal goes far further than this. So the proposal is that we try and take a far more transformational approach to the work, that we start with the race model, which is one that is the team have researched, and I'll describe for you a little bit about in a minute. But then really importantly, we underpin it with the trauma-informed practice that we've already touched on earlier today. So if I start with the 4-step race model, the team there's a number of them out there, and the team have decided to go with Shireen Daniels and the work there that's done as part of the anti-racism organisation. And it's a stepped process which gets us to make sure that we recognise the problem. And I can think of many difficult conversations I've had over the years where we've had quite a difficult conversation about white privilege, and even whether people understand the concept of white privilege and how that sits in an anti-racism setting. So I think we would be underestimating the challenge if we didn't really acknowledge just how much we've got to recognise the size of the challenge that we are trying to improve. The second step in the model is that we analyse and we take some actions. So those will be in both policy and practice and culture and relationships, that we recognise the context within which we are all working, and then that we empower and we evaluate. We empower for change and we evaluate that change. So that's the step model that we're proposing we take. Underpin that, though, really importantly, we just heard a little bit about that this morning, really, around trauma-informed practice. It makes sure that when we're trying to operate with these plans, which we can often see as quite transactional, that we stop to be aware of that trauma can impact anybody, and it can impact in different ways, and it can stem from different life experiences. And of course, trauma and discrimination are 2 things that go hand in hand and are therefore very important to make sure that we are taking a trauma-informed approach to the work that we do. So again, the model starts with, let's be aware of the fact that people, as our patient was describing this morning, there will be different things that will mean different things are important to individuals. And therefore we start from a person-centered perspective. We notice the signs. So I'm really struck by, it took a Black member of staff many years ago now to say to me, could you please stop asking the people that have been hurt the most to keep telling their stories? Because that in itself is reliving the trauma, which is why in my previous organisation, we published a book of all of those stories to stop them having to do that. So I just want to try and bring that trauma-informed piece to life, where we have to stop and consciously think about our actions and what that might mean from a trauma-informed perspective. So both organisations have been doing some fabulous work over the last few years. The teams have, because of our intent to join, have been working together over the last few months anyway. And there is a lot of work where they are already doing listening events, focusing in on training for our people, particularly making the link with violence and aggression and how discrimination shows up in that particular space. One of the organisations has got a racial psychologist, and her insights are just absolutely invaluable and are being shared across both organisations. Both organisations have engaged the experts. So Roger Klein, Eden Charles, we've both, hopefully you'll remember it, working with them. There's some lovely work already in both organisations around sort of active bystander scripts. So how do we get all 28,000 staff to be able to step into this space confidently? And I'll just come back round to that piece in a minute. Both have got really, really strong staff networks. I've met with all of them. And only just over the last 4 weeks, we've been jointly celebrating Black History Month. So some really good foundational work in place. But I think if we take the structure that we're talking about taking, what we're proposing we do is to take the next 6 months to focus on the things that we want to do together. One of the organisation's listening events have done the evaluation and are responding to that and have picked out the themes. And those themes were HR practice, learning and development, and very specifically recruitment. That came from listening to our people in the main. Rather than prejudge the outcome of just assimilating all of the information from the other organisations' listening events, that's being done now, and we think, already having scanned them, that those three are going to emerge again as very strong areas of focus. So the work we're proposing to do over the next 6 months is make sure that we strengthen our training. One of the areas that will be in the OD and culture plan that goes a bit further is making sure that we as senior leaders feel really confident in this space. I suspect if we were to take a temperature check, not all of us would feel confident about calling out discrimination in the moment, or feel confident in taking a trauma-informed approach. So I want to make sure that we're role modelling and leading from the front with that expertise and with that knowledge and building that confidence together. We'll percolate that down through the organisation. There's some lovely learning and education that is in both organisations, and they both marry up very nicely. And then we'll very specifically focus in on some of our HR practice. And I think bringing this to life, we were talking earlier about the OD and culture plan supporting the merger. So I'm challenging the team back to make sure that we're seeing this in the moment. So where are we hearing the voices of our marginalised people in our merger plan is the question I'm posing of the team. And where are we making sure we are going through huge HR process change at the minute. There are so many teams going through organisational change, recruitment and selection processes. How are we making sure that we are not bringing bias into any of those processes? So I'm trying to also make sure that whilst the plan that you've got in front of you is strong and I'm delighted to be able to present it. I think there's more. We've also got to be doing a check and challenge in the moment to say, so when we look at the plans around this table, do we see the the issue around anti-racism and more broadly discrimination feature in everything that we talk about here. So the purpose of this really is to get your support for the approach, to help you understand the structured approach with the framework that we're proposing to take. And of course, we'll make sure that we sort of put this through some governance, and I'm challenging back to the team to say, and how will we measure whether this approach has been fundamentally different from many others that we have been trying in society to use for decades. So
thank you very much, Jenny. Who would like to kick off with this conversation? Martin?
Yeah, happy to. I mean, really enjoyed the paper and your presentation of it, and absolutely agree with the model, and I'm really happy to hear that. I think you're right. We should be embedding more widely as far as it possibly can, and not just having a standalone thing that goes on the shelf, even though we also need that to prioritise it. I suppose the one thing you sort of touched on at the end, I thought we could perhaps strengthen or put in the work plan for the next 6 months, is that sort of measurement aspect.
Mm-hmm.
And whilst RES and DES are the sort of gold standard in a way because they're nationally comparable, so out of date in a way, and once a year we don't get a lot of data at the fore to say really how we're doing, so if we could think about, is there anything we can do on a more regular basis to give us some insight, how much in our sort of IQPR report do we on, just to keep a finger on the pulse of how we're doing with it. Something that would be sort of icing on the cake here. How do we know we're succeeding?
Yeah. Do you want to collect them up and then I'll come back round?
Should we do it that way? That's fine by me. Mark?
Roy was first.
Oh, Roy, okay.
Thanks, Mark. Thank you, Jenny. Firstly, fully appreciate the commitment to the anti-racism work and making it meaningful and effective. The sort of the logic behind the new framework makes a lot of sense. And I'm saying it's a new framework because, we've had several iterations and discussions of where we want to go to. So that makes sense. I'm aware that sort of repeated feedback from colleagues have been, we talk about our experiences and nothing changes, right? And so and I think the slides mentioned lip service, within quotes, lip service. So the question in my mind is, as we take the next 6 months to further refine this framework, how do we sort of demonstrate to our colleagues that this is actually going to lead to some change? Is there an action plan? Martin, your question around sort of what specific is coming out of it? Because we've had several listening events, and my worry is we do within the new framework we do more of these things, and our colleagues feel like nothing changes. So. Sort of a bit of a blurry question there, but essentially, how do we make it concrete so we can demonstrate the changes being made?
Yeah, no, definitely.
If I'm there, it's just probably a better way of putting it. I'm always data-driven, but you're experience-driven, so
Mark?
Yeah, that's one of my points is around being experience-driven. It sounds like an apology that if I missed something, and Maria, if I go back to our conversations yesterday in the recent health equity group, if we are changing the language from pro-equity in one organisation through to anti-racism for the group, if we are doing that, that'll need some explanation, and that will need some really refined conversation around why, because they both say something different. And I know that'll probably be covered somewhere, Jenny, but that needs to be carefully considered because it does mean different things. I know there's a long debate at UHBW around, do we call it pro-equity, do we call it anti-racist strategy? So I wouldn't want to lose sight of that. And then the only other point I had was, how do we also make sure there's linkage through to the leadership work and the wider mentorship work for our junior leaders, our middle leaders, our senior leaders, because these two for me go hand in hand, because it's in the pack. That thing called allyship is really, really important. And whether they call it pro-equity or anti-racism, allyship is vital to making this work, and it can't be held by the minority. It has to be held by everyone across the organisation. So I hope that's helpful.
Sarah?
Thank you. So just a further reflection on the fact that we hear from many colleagues that it can be patients or the people who are with them, their carers or families from whom they perceive that they experience discrimination and harassment. So just thinking about how we can play a part in communicating outside the organisation. We have much to do inside to put our house in order, but communicating outside that this is not acceptable, and it's not only not acceptable within the Bristol NHS group, it's not acceptable. Full stop. And how we can be leaders in it as well, being anchor institution.
Okay. So let me start first of all with the different approaches, because this is a really important thing to pay attention to when we talk about culture and culture change. And there is a distinct difference that both organisations have taken. UHBW have taken the branding of pro-equity, and MBT, very strong statement around anti-racism. When I better understood that though, Mark, UHBW really reassured me that there are anti-statements below the pro-equity umbrella, and therefore there is still no reason why we can't talk about both. But when we talk about both in UHBW, we talk about it in the context of the umbrella. But both anti-racism resonates in both organisations. The piece on measurement, one organisation does this and the other is learning to do it. But because of those strong statements, the UHBW is measuring through the staff survey pulse survey how much awareness there is of the pro-equity brand, what it stands for, and how well it is understood. And it's using the quarterly pulse survey to ask a very specific question and measure its way through that race model. So it's already got a measure of the level of awareness in the organisation about why this is important and how we and where we position it. So I think there's more we can do on that type of measurement that will help us step through that race model. The actions that will make the biggest difference, we're trying to do at various levels of staff group in the organisation. So I'm challenging the team at the minute to say, what is it that our senior leadership team, when we talked about this framework and trauma-informed leadership, I'm the first to say that is not a space that I feel completely and utterly equipped to operate in. So us feeling equipped as a senior leadership team is going to be vital. So I'm just getting the team to make sure that we're all given the support and the education and the input that we need to be able to ask the right questions, role model the right behaviours, etc. The violence and aggression piece is one that is very centre stage in some of our staff feedback in the last year's staff survey, and that is one where we can start to use that allyship piece in that setting, because it's there's a violence and aggression programme within which we're bringing anti-racism and broader discrimination and that race trauma-informed approach into a programme that is running on a different topic, if that makes sense, but has a very strong discrimination element to it. So we're just trying to pick the things that we think will make the biggest difference, and go where there is already a lot of energy.
Really helpful. Thanks, Jenny.
Mark, I'm picking up again on some of our conversations yesterday. And the strength of feeling in the room at various points, and the feedback. And I remember Habib Naqvi saying this as well. Language is really important. And actually, one of the take-home messages I got from yesterday was, public sector organisations say they're going to do a lot. They're hopeful of doing a lot. You look at the data, not much has changed. And actually, it's perhaps more about saying, making it clear what we will not stand for, what we will not tolerate, as a more powerful way of expressing what staff and patients might like to hear. I mean, the fact is, it's not an either or. We need to do both, don't we? But I just wondered in terms of the public statement on what we won't tolerate, whether the anti perhaps was more decisive.
I would agree with that, but that's my personal view.
Yeah.
And I think we can manage that in UHBW. I really do. I think the reason for the umbrella pro-equity piece is UHBW's Res and WOODES data highlights a particular issue for them around, or for us around, disability, more so than in NVT. So I think there are some data reasons as to why UHBW have worked that way, but I've heard no pushback from anybody that says they don't recognise anti-racism as a very clear statement within UHBW. It just sits underneath the pro-equity brand.
Okay. I think we are. Last point.
I'm just agreeing with Jenny about the anti-racism thing. I mean, I'll just remind board where that came from. And where that came from, the anti-racism statement in UHBW was written by our staff.
Yeah, it was.
And it was written by our staff as a response to all of the listening events that we held. And then was read out to all of our staff as a reminder of our stance. And there was no doubt whatsoever in my mind in our staff's perception of that and acknowledgement of that and alignment with that. So I think it's very, very clear there is no mixed message in UHBW about pro-equity versus anti-racism. They'll sit alongside each other very comfortably. And we went through a very robust process to get to our anti-racism stance.
Yeah.
So please be absolutely aware of that.
Yeah, I would support that. And I think it's really interesting, isn't it, as we move forward in a group, that actually probably if you went to each individual unit or hospital, they will feel slightly different. But I would urge, we just do need to remember the work that was done at UHBW to get. And if there is a change in messaging, we just need to be really careful about how we handle that. Because we don't want to devalue, because we're saying we're going to listen to you, but actually we've listened to you, but now it doesn't quite fit, so we're going to make it something else. So I just 100% back up what Stu is saying.
Yeah. But Stu, I don't think there's an incongruence, do you?
No.
I really
but it's the handling and the messaging, isn't it?
Comms. I'd be very, very wary about changing that message, having been written by our staff in response to a very significant and prolonged listening exercise. I think it'd be a real risk. So
totally agree.
And that was my point too, in terms of how that's managed, in terms of across the group structure.
But there's no incongruity. What you're saying here is absolutely the next step. I agree. I agree. Yeah.
It sounds like we're in violent agreement, doesn't it? Really. If there are no other comments, could I just reflect? This is really, really, really important. It is quite internally focused on our colleagues, and we must not forget the work that we did in a board development session with Habib Naqvi and others, some of our other colleagues, around health inequalities experienced by the people and communities we serve. And that was written up, wasn't it, Xavier, and circulated to board members. But I think we need to revisit it and make sure that we have got it, as I know Xavier is planning, really embedded in the governance of everything that we do, so that we don't lose focus, because they're two sides of the same coin. But not to detract in any way from this is vitally important stuff. So we are being asked to discuss the approach outlined, and specifically the commitment and support to our anti-racism approach, which I think we have absolutely expressed, the use of the race model, and that needs to be underpinned by this trauma-informed practice, We've talked about the work plan for the next 6 months, and there were a couple of additional points made, which I'm sure Jenny will pick up, about impact and evidence, both data and experience, and to restate our overarching anti-racism aim, which is to eradicate racism within our organisations. So there we have it. We're not being asked to approve, but I think we are affirming the direction of travel and our commitment to it. So thank you, colleagues. Shall we move on then to the group integrated? Can I just say though, before we do that, it's been fantastic today, I think, to have so much emphasis on the big picture strategic stuff, which is what we promised ourselves we would do as a group board. So thank you to everybody who has made it so. And now we are going to go into a far more operational space in looking at quality and performance and the group integrated quality and performance report. I'm going to ask Stu and Glyn to kick us off, particularly looking at the responsive element of the report, but also just framing it more broadly, if you like.
Yeah, okay, thank you. So, Glyn, I'll go first and then come across to Glyn. In terms of urgent care, the report, of course, covers up to the month of September, but to flag up, we continue to have a very challenging urgent care environment. For September, it does state in the report that our system ambition for delivering no criteria to reside, for example, was not achieved. And just to put some flesh on that bone, the average no criteria to reside patient number in UHBW for September was 186 versus a system ambition of 152. For October, that gap widened. For November, there has been a significant shift. Now, that significant shift so far has occurred on the background of the critical incident, which occurred firstly in UHBW, but then across the whole BNSSG system between the 30th of October and the 4th of November, which was a consequence of the high operational unscheduled care demands, and specifically the high number of no criteria to reside patients, sort of early and heavy flu season. And as people are aware, the closure of 2 of our wards, temporary wards put in 2002, which had come rather prematurely and precipitously to an end of valuable life, and we had to close those. And that precipitated on top of those other factors, slipping into critical incident. Today, our no criteria to reside number is 155. So that is a sea change, and that is a consequence of, as Maria flagged up earlier, the system response to that huge operational challenge in the unscheduled care space. So I would likewise wish to flag up the huge support we have had from system partners in dealing with that very serious combination of challenges. And of course then, the ongoing issue is maintaining that improvement in, and I would also flag up that is absolutely recognised by system partners now. Our system partners are working very hard to maintain that improvement. So that's where unscheduled care is. The THP, the handover protocol, has had a knock-on consequence on our 45-minute performance, as you would imagine. And the report here flags up a performance of 10% over 45 minutes. That's now dropped to around 3 to 4% as a consequence of that. That has a direct knock-on consequence on our ability to move people through the department, though. And so let's just be clear, there is a consequence of that in terms of other components of our unscheduled care performance. In elective care, our RTT will be on track percentage-wise for performance in October. And board will know we've had some issues in ENT and cardiology, and we're seeing very good recovery in both of those areas, and total waiting list size is also reducing again. So that's a really important metric we're being assessed against. We continue to have some challenges in children's dentistry related to general anaesthesia administration, and I have a recovery plan implemented in there. In terms of cancer performance, people will know we remain on in alignment with trajectory for 31 and 62 day performance. Our FDS performance, though, was off track in August and September. That's a very small amount of people will have seen that. And that related, as I flagged up last time, to some head and neck staffing shortfalls. We anticipate being back on track for October. And we also anticipate being in alignment with the target of 80% by the end of the year. So that's good work. But of course, now how could I, in the light of the story we heard earlier, only contemplate our trajectory of performance and have to now add in the patient experience component and how we need to also make sure we're focusing on that as we improve those operational performance metrics. Finally, I'll just touch upon diagnostics. And so it's interesting in Maria, in your report, the 1% aspiration for the medium term planning framework that in diagnostic space, that continues to be our aspiration. And we have had a bit of a slowdown in our improvement as we move towards an aspiration of 5% by the end of the year of 6-week breaches. So that was probably all I was going to say on our operational performance, but happy to, the other one point, children's ED, of course, children's winter does start a little bit sooner than adult winter. And we have an upturning demand in children's ED, but nevertheless our performance remains strong. So I was just going to flag up that specifically for our children's hospital.
Great, thank you very much. And for colleagues' awareness, Maria has just been called into a national meeting about industrial action. So that's why she's had to leave us at this point. Stu.
I'm glad.
Sorry.
I'll start with the sort of good news side from MBT. So we are slightly, we've fallen off our less than 1% diagnostic position just on a couple of areas in DEXA and neurophysiology, but only to 1.3%. So we'll recover that again next year. So diagnostics is in a really a strong position. RTT, again, we're on track to have less than 1% by the end of the year. We're almost, we're achieving that already. We aim to get well ahead of that in time for next year, by the end of the year. Urgent care, Stu has covered many of the issues that we've experienced in both trusts in a similar way. The one thing I would say is MBT is seeing ever higher levels of attendances. So yesterday we hit 374 attendances. If I roll the clock back 12 months, we were seeing 320, 330 as a high day. We're now hitting 320 almost every day, and 374 is the peak. And following that, we had a quick meeting this morning. We're going to have our trust management team tomorrow trying to figure out what does a 400 person day look like, because I strongly suspect that January and February we're going to be dealing with that level. No criteria to reside. We remain with around 170 to 190 patients with no criteria to reside, around 60 or 70 more than we should be at by this stage against the plan. And I guess I just want everyone to be aware, we are running at around 80 patients in escalation areas. So escalation spaces are beds in the boomerangs outside wards and on the end of wards where people don't have the privacy and dignity. Certainly they're not the places we would like to be caring for people, but they are the sort of least worst way of managing the pressures. And then similarly, we open what we call cohorting areas in ED. I would really welcome sort of to take board members around what those cohort areas are like. We open them when they are safe, when we can staff them, so they are safe. Patients are safe in those areas, but they are lacking the privacy and dignity that we would all want to give to our patients. But that's the position we're in, and I don't want people to see when we talk about escalated patients, this is what it means. It means often elderly people receiving care in places that we would rather not provide that care. But there are the big change around the ambulance, the ambulance timely handover protocol. It has put extra pressure into ED. So we are talking to the system. I represented Maria at the recent Integrated Care Board, where there was a really helpful discussion around it. When we have a surge in ambulance attendances and our ED becomes massively congested, we push patients out into the hospital ahead of when the wards have got spaces for them, and that results in these extra escalation spaces, the boarding, etc. We have got to have the safety release valve of being able to discharge patients at the other end. So we have almost 200 patients who don't require acute care. They do require care, so it's not the patient's fault that they're there. They require some support in their next move. We've got to work with the system to get that emergency. All says we've hit a critical incident. We now need to discharge 20 patients immediately to allow that flow through the hospital. I had a conversation with Jo Veer, the new chief executive of Sirona, and we just need to. She's very supportive, and we need to get those conversations happening really quickly. And we need to really start to ignore organisational boundaries, because it is risk that is sitting in the system, and we need to put it in the most appropriate place. So I'm positive that this pressure is going to result in some changes going forward. Moving on to cancer, which is the other area where MBT is behind the ball at the moment. We are off our plan on faster, the FDS, faster diagnosis standard. Urology, which is by far our biggest specialty in this area, it improved month on month, but not enough to recover where we'd hoped to within the plan. And then both breast and skin, which have been overperforming in these areas in FDS, have referrals have really increased in the last month, which meant they've not been able to cover some of the underscoring on urology. And so we have put a recovery plan in to get back to our original plan, and that has been accepted by NHSE. We now need to monitor delivery against that. Also on the 62-day standard, we have two main areas that are falling behind, which is breast, and that's at both screening and symptomatic stages. Both of them are down to radiologist capacity, and it's a national issue for breast radiologists. So we're working with Region on how we recover that, and we have a plan for the extra capacity that is coming on over the coming weeks to help us recover by the end of Q3. And then urology, again, we have a very high referral rate outside of BNSSG, and urology cancer seems to be quite fragile across the southwest, where we are ending up picking up patients outside of our typical cohorting area, and we're having to deal with them because of where they are in their pathway. So we are trying to work with the region to understand what the expectation is on us as a tertiary centre in terms of picking up, because we're picking up patients who are late presenting rather than with the acuity that means they should be coming to us. But because they're late presenting, the importance on seeing them sort of starts to trump patients who are waiting in our area on a clinical prioritisation basis. We have got a deep dive coming to the QOC in November. It was supposed to come in November. It's coming to the next QOC to make sure that we've got the clinical director and the COO both able to present there.
Thank you. And particularly thank you for spelling out the realities of what cohorting and no criteria reside actually mean for real people. Yeah. It's really important to recognise that. And again, especially in the light of the conversation at the start of the meeting. I'm really conscious of time, colleagues. I'm sure there are loads of questions, but I'm going to push us on through the report and then pick up anything pressing at the end. So, quality. Steve.
Quality performance has actually been reviewed by the Quality Committee, but just three things to very quickly highlight. The UHBW MRSA deterioration, in fact, there's been a further case in October. We have strengthened our broader approach to the range of interventions and improvements for that at UHBW, but also learning across MBT and the wider NHS. So there's an NHS collaborative that's going on around that. So the team have been able to isolate some of the causes, which we're now doing the improvement work on, relates to Lyme care specifically. In terms of complaints for MBT, there has been a deterioration, although October has improved. a recovery plan was developed by the CR, and that seems to be working well, which is good. And then just the final one for MBT was just a slight spike in pressure ulcers in one area. Again, looking at the data for October, that has now restored back to normal. But the team are just looking for any areas of learning. Very happy to take any questions, but I know that Quality and Outcomes Committee looked at this in great detail last week.
Okay, great. Thank you, Steve. People. Jenny, anything to highlight from the report?
So this was my first people committee, and it was in my notice period. So, but it was great to be able to join. It was our second committee in joint, and the team did a really good job of making sure that we reported up through all of the people issues on the from both hospital sites perspective. We did a deep dive into the area around training and education and making sure that our trainers themselves are equipped to be able to do the am I on the right item?
No,
Looking at
I was just wondering how to break it to you.
No, it's right. just tell me.
So,
tell me.
no, it's only on the integrate on the IQPR. Is there anything particular? I mean, we will hear from the committee in a moment.
I've gone ahead.
You've jumped ahead. Right. It's wishful thinking,
Yeah,
Jenny.
no. I've definitely gone ahead. The only couple of things I wanted to pick out were obviously, just from a good exception perspective, the retention piece, it's great to see those graphs going in the right direction for both organisations. Vacancies in, so two exceptional areas that you'll see reported, vacancies in MBT and some very specific work around healthcare workers. And also just the needing to staff a particular ward that is opening and is currently being staffed with bank, but some clear actions in there in order to be able to make sure that that position is clear. And then again, some focus in MBT around sickness. So they're putting a lot more emphasis on the timeliness of case management and particular focus on our unregistered staffing cohort, making sure that those are the areas where we're seeing some of the highest sickness levels. So focusing the efforts of the team there. The only other one I would just want to draw the board's attention to is the one around mandatory and statutory training. You'll see that we're still trying to make sure that we are aligning the IQPR across both organisations, and to move to the top 11 NHSE core skills topics, plus Oliver McGowan. I guess just to say, though, we need to make sure that we stay alert to the work that is being done on statutory and mandatory training nationally, because the training piece tends to be the go-to place for a solution to a problem. And some of what is being measured and acknowledged nationally is that those risks are still reporting at risks that at levels that remain constant, and therefore questioning actually whether training and education is the go-to answer in this space, and whether there are other risk-based mitigations that would have a greater impact than the automatic default being training and education. The key in there is just making sure that those other risk-based actions are identified and we're clear that those are being taken. But that would free up a lot of time operationally, clinically, if some of the direction of travel nationally were to slim down some of that list. So we'll just make sure the reporting stays in line with that.
Okay.
Sorry, I'll get on the right page.
Thank you, Jenny. And finance, Neil, highlights from this element of your report.
Yeah, thank you. As is often the case with the time of the board meeting, I can bring the figures in the pack up to date in terms of month 6 is reported, but if I turn to month 7, so for MBT, month 7, a 3.6 million deficit against a 2.9 million deficit plan for the year to date. Equivalent figures for UHPW, an 8.3 million deficit against a 7.6 million deficit plan. So both trusts reporting circa 700,000 adrift from plan, which is entirely due to the cost of the industrial action back in July. So in month 7 we are reporting in a way which is more consistent with the rest of the country, and that's also one eye on the potential costs of forthcoming industrial action. Cost improvement, financial improvement for the year to date, MBT have achieved 16.3 million, UHBW 29.5 million, so around 46 million for the year to date. And I can compare that with the 50 million that was achieved as an outturn last year. So really fantastic progress in terms of in-year delivery. I was briefly going to mention UHBW capital plan. In previous years, this has been a bit of an issue in terms of slippage during the course of the year. But at month 7, £40 million worth of investment delivered, so around £2 million ahead of plan. Think about the second half of the financial year. The operational themes that both Stu and Glyn have highlighted are clearly very pertinent. So in particular, the costs associated with the escalated capacity. We do have a proposal from the ICB to offset what we estimate at £11 million worth of additional costs, with a £6 million allocation in the second half of the year. So clearly this doesn't defray from the points Glyn raised in terms of operational and patient experience, but just show some system collective responsibility in terms of the financial impact. The system overall is reporting at this point in time a risk in terms of year-end delivery of circa £14 million. However, very strong collective commitment to manage that between now and the end of the financial year. We will, however, keep that under review during the next month, with a critical ICB board meeting on the 4th of December, where we need to complete our assessment in terms of confidence around year-end delivery.
Thank you very much. Any pressing points people feel the need to raise? Sean?
Just very quickly, on the slides where we put a corrective action in place to improve things, it would be really handy to have a time or a month when we expect to see some benefit from that action.
Okay.
And just a quick second one, picking up on the Oliver McGowan, just making sure we're on the trajectory to hit the 66% of the level 2 by March, because we're some way off it just at the moment. So I just wanted to make that point.
Right, we've got a forest of hands. You're obviously not hungry. Mark, and then
Sorry, Madam Chair.
and then Roy.
Just a point about the breast radiologists as being a bit of a struggle there to recruit to. I'm sure this is the case, but are we really pushing the advanced and consultant practice and dimensions for colleagues to be able to report, to be able to actually provide MET support? It's not always just about stopping it with the radiologist. There are other ways of providing the service in new. It's not an inferior route through. It's about just how you progress your workforce, so that advanced and consultant route would actually give you a paid way to people and keep those services going. So I think thinking about that's really important.
Good point, Mark. Did we get back to Sean on the Oliver McGowan point? I think point well made on we can refine this IQPR as we go, can't we? Oliver McGowan.
I'll pick up the action on the trajectory.
Okay, thank you. I think it was Roy and then Sue.
Thank you, Chair. And I don't have a question, but I felt like I had to really acknowledge the operational challenges that we're facing, especially with the corridor care as well that Glyn highlighted. Martin and I, we visited Southmead a couple of weeks ago, and it is obvious. It is. We do not want our patients to experience being in corridors at all, and fully understand the inconvenience and patients. It's not where we want to be, but I think our red line is safety. And I think that's what we're doing. I think even though it's suboptimal, as long as we don't cross the safety line, I think we are doing the best we can. So I just wanted to acknowledge a difficult time for both trusts at the moment.
Thank you, Roy. I'm sure that's appreciated by executive colleagues particularly.
Yeah.
Sue?
Quick question. I think it's for Tim. VT risk assessment, UHBW. The figures aren't particularly improving. It seems to be we've had a steep increase and it's plateaued. Considering it's mandatory, why is it now stuck at 82% if it's a mandatory element on CMM? And when can we?
So I was going to hand up and sort of just to backtrack a little bit, just to often my colleague to the left knows that I'm going to sort of criticise this digital system doesn't work, that doesn't work, etc. But actually, I think this is a case in point of successful implementation for EPMA. You'll notice that both the medication incidents and VTE risk assessments both improved at UHBW at the time of launch, and hopefully we'll see that at NBT. So thank you, that's a very successful implementation. Why are they stuck where they are? So we're looking into it. So I think what we know is that there are, it's usually the bits that have squeezed, it's usually bits that have escaped down the gutters really. So there'll be areas of practice where there isn't any recording, where there are sort of day cases done in procedure rooms where people are not recorded. So we need to flush those bits out. We've done that at NBT and got to where we need to be, and we're waiting for EPMA to give us that next leg up. I think we've done it a slightly different way around at UHBW. We've done the electronic prescribing. Now we can flush out the little areas where we're leaking around the edges. So it's a very good point. And you know, our ambition is to be exemplar status, not just compliant, but exemplar status, which is where we were 3 years ago. So, thank you. Thank you.
Are there any other thoughts? We haven't talked about the maternity and neonatal stuff, but I know that has been considered in some detail at Quality Committee. So, is there anything the board needs to be aware of? Okay, so thank you everybody. That is for information and note, and we'll move on then to the committee upward reports, where we will highlight the areas where board awareness, action or response is required. So digital, Roy, doesn't look like there's anything.
No, there isn't.
Particular.
No.
Okay.
I'm happy to take questions.
Linda on people.
The only thing that I'd like to highlight is just how well the two trusts are starting to work together. I think we spent a lot of time looking at how we can jointly change how we work, both in terms of back office and the outwardly facing offering. And I think it was Jenny's first meeting. She actually joined in her notice period. But, you know, we took some time to look at how we're supporting the delivery of the 10-year plan. We took some time to look at the BAF. We revisited the risk framework, and we spoke about aligning the trust policies and processes around group development. So I think, you know, I'll take the paper as read, happy to take any questions, but nothing significant.
Okay, thank you very much, Linda. Shall we move on then to Quality and Outcomes Committee? There are actually 2 of these, but I'll take them in the order that they're in the pack. So September, Sue, you chaired this one.
Yeah, as you say, there's been 2 meetings. So this was the September one, and you can see the a big focus of this meeting was the discussion around the winter plan, which I think we've covered. I'm just happy to take any questions.
Okay, thank you. And is it worth just highlighting the maternity champion issue for clarity?
Yes.
Because it does refer in this paper to it being just Sarah, but in fact it's Sarah and Sue together doing the maternity champion role, just so everybody is crystal on
Yeah,
that.
there were a number of questions. Something in the minutes, terms of reference that needs bottoming out around the non-exec director roles, which I think we're getting on top of that. But yes, you're right. The absolute clarity around maternity champions.
Well, thank you. Let's move on then to finance and estates, and there were 2 committees, September and October. Martin, anything that board needs to be particularly aware of? Obviously, fire.
In that slot, fire was which we're saying there should be an update report on fire, which is coming to the board, so we will see that separately.
Okay, and on the October one, have I got that right? Yes, October as well. So they're conflated, I see.
Just the recovery plan, which is an audio report.
Okay, thank you. And then audit, Richard.
Thanks, Chair. It's a bit like a broken record, really. I think the key point was just highlighting the need for board time and space to consider the BAF, revisit strategic priorities for next year, and any new risks arising coming out of the merger and the left shift, which all need to really feed into a revised set of group risks. And it's just the timescale to be able to do all that. Yeah. Then secondly, we had a bereavement report, which was great. It highlighted UHBW bringing the 4 separate bereavement services together, but it was decided actually quite a good idea to roll MBT's bereavement services into that, so to leave it to a post-merger sort of scenario. But we just wondered what the mechanism was to track all these potential opportunities to make sure things like this doesn't get lost and sort of disappears into the long grass.
So is this something that we can pick up, Xavier, to highlight to Paula and Robert and others working on the merger programme? Make sure we do capture these things. In terms of the board time for strategic thinking, amen to that. And we are really keen to get those dates absolutely nailed in the diary, because in addition to the facilitated time with the Value Circle, we want to continue with the other board development days that have been scheduled in to do exactly this kind of piece. Richards.
I'm just conscious
very
that
much there, but aligning it with the timeline is a different matter. Yeah. So, okay. Anything on the quality committee that you chaired, Sarah, which would have been the October one?
Correct. So we received a number of very important reports on behalf of the board: HTA compliance and full inquiry compliance reports for both trusts, organ donation report for UHBW, and the safeguarding report across both trusts. So we considered those on behalf of the board, assured by what we saw within them, and there were a number of very important decisions we had to make on behalf of the board relating to data around maternity and neonatal services, and those are documented in the appendix, but we were fully assured on those matters.
Okay, thank you very much. And I note your chair comments about the volume of information and data, and we are just on a journey in this, aren't we? I mean, we know it can be done because we've looked at other enormous trusts and groups and they cope, but it's refining it and using our committees below board committees to be able to give assurance in a different way. So, yes, point noted and understood. Is there anything else that people need to raise before we break for a lunch? Okay, well, thank you all very much. Apologies, we have finished a few minutes late, but maybe we could start a few minutes late as well. Part 2. Thanks for coming, everybody. Good to see you.
What are you doing? Hello? Jeremy likes to talk to you.